Alright, so the PowerPoint slide that we're going to be discussing in this lecture is assistive listening devices and implantable hearing aids. So far, we've talked about diagnostic testing, and in our last two slides we've talked about hearing aids. So I think at this point you have a clear understanding that certainly after we do a full evaluation of our patient and we assess their needs, the first step in the rehabilitation process is fitting hearing aids and working with those patients regarding hearing aid fittings. And we're going to get back to that concept with talking about hearing aid group orientation, and also one thing we haven't discussed yet is verification measures. So we will be continuing on with this topic, but alongside the fitting of amplification or hearing aids there's additional devices called assistive listening devices, or ALDs, and then another type of hearing aid are implantable hearing aids. So two other options depending on the patient's needs and depending also on the degree of hearing loss. So what are assistive listening devices? And I'm going to read this from the slide. Assistive listening devices, or referred to as ALDs, assist in hearing and or expanding the functionality of hearing aids and cochlear implants, and we'll be discussing cochlear implants in the upcoming slides, by helping you or helping the patient separate the sounds that they want to hear from the background noise. So we've already talked at great length about improving the signal to noise ratio, improving the signal, what the patient is trying to hear, the conversation they're focused on, and basically pulling or separating that signal, what they're trying to hear, and pulling that out of the background noise, so to speak. An ALD usually uses a microphone to capture an audio source or the sound source at its origin and broadcast it wirely over an FM, or FM stands for frequency modulation transmission, either through infrared technology or an induction loop method or technology. And we're going to talk about those two, infrared or induction loop. So I want to make sure to clarify, assistive listening devices can be used instead of, in some cases, or in addition to hearing aids. Okay? And you're going to see those in the types of devices that we discuss. These devices are very important for audiologists to be familiar with, because even with hearing aids, our patient could still be struggling in certain environments, so that we can make additional suggestions. Or maybe a patient has a very mild hearing loss, yet there's certain situations where they're struggling in, so maybe assistive listening devices would be more helpful in those situations. And there's some other scenarios that will come up. Why is knowledge of this important for speech-language pathologists? Because you may actually find that in therapy, particularly with an older population, the geriatric population, that you may even keep types of assistive listening devices in your office, because you may have clients come in, or maybe working with a client in the hospital post-stroke, or patients with aphasia, patients that even come to your practice, or that you even see bedside in the hospital, or in a nursing home, in a rehab facility, that have lost hearing due to some sort of injury that is part of the cause why you're seeing them, or they are in the hospital that they've left their hearing aids at home. So this topic of assistive listening devices is especially pertinent to those of you who will be going into the profession of speech-language pathology. speech-language pathology, so that you also can have these devices on hand or be familiar with them to recommend them to patients who are struggling, or to utilize them in assessment in an emergency or hospital environment, or let's say a patient that you're seeing on an ongoing basis forgets their hearing aids at home, or they don't have their hearing aids during therapy because they're broken. So that way you would have other devices on hand to utilize. Alright, so when we talk about assistive listening devices, or ALD technology, there's several different types. There's different types of technology that these systems utilize. Okay, so ALDs such as audio loops, FMs, or infrared systems are kind of like binoculars for the ears. They can work with or without hearing aids. So let me read through this and then sort of give you some examples so that you can picture them in your mind. So we're talking about just the next 3 points that are listed in yellow are different types of technology that is part of an ALD, how they work, and these are also listed in your text. So first, let's define an audio or induction loop. An audio or an induction loop is a wire, and I think you'll also see some images in the upcoming slides, a wire that circles the room and is connected to the sound system. So sometimes these are utilized in like conference room settings, or places of worship, or theaters, places like that, because it can cost $2,000 to $5,000 to have this system put in, and that's an approximation. So a wire is laid that kind of encircles under the carpet or the base of at the walls of a room, and it's connected to the sound system. So this loop or wire transmits the sound electromagnetically, and the electromagnetic signal is then picked up by the hearing aid through the telecoil option. So remember when we talked about features with hearing aids, and we talked about a telecoil option, where a hearing aid may have an option that either the person pushes the button or it happens automatically, that when a telephone, and we're talking about a landline versus a cell phone, when a telephone gets close enough to the hearing aid can pick up that electromagnetic signal of the phone and instantly switches into telecoil mode to amplify the voice on the phone, and only the voice on the phone. So if you're on a busy street and happen to need to use the payphone, again, if you can even find a payphone anymore, the hearing aid would only pick up the electromagnetic signal of the phone and decrease or you would not hear any of the other noise. So again, significantly improving the signal to noise ratio. So as we know, landlines and cell phones and those types of telephones, or not cell phones, landlines, phone booths, these types of telephones are basically becoming obsolete. But individuals, and oftentimes still our senior population, still has landlines in their homes, or oftentimes working individuals have landlines or office lines in their office, so that their hearing aids, when they get close enough to the receiver, the hearing aid instantly detects that, switches over to telecoil mode, and without getting feedback, you can get the piece of the top of the phone that you're holding to talk into right up against the hearing aid without getting feedback. That's the telecoil. But since landlines, as I said, and phone booths are basically becoming obsolete, this loop system is still very beneficial. So if an individual, if a room, for example, and we say that a room is looped, so let's say you're going to a place of worship and it's looped, if you wore hearing aids, you could either set or automatically put them in telecoil mode. That way, when the minister or whoever is leading the group is speaking, that sound is connected through the loop system and will go directly into the individual's hearing aids. So that's the concept of the induction loop. This can be set at theaters where there's plays, movie theaters could be looped, concert halls can be looped, places of worship, meeting rooms, conference rooms, those places can be, we call them looped, or the use of an induction loop. Another system is an infrared system. This uses an invisible light beams to carry the sound from the source to a personal receiver. So in the first point, the induction loop, I use the example through a telecoil option. So this would be applicable to a person who's already utilizing hearing aids. But let's go back to the first option, the induction loop option. Let's say the person who utilizes hearing aids is going to play, and they don't have front row seats, even though they have hearing aids. What I didn't mention maybe is that the microphone on hearing aids, and any hearing aids from completely in the canal to behind the ear to open fit to receiver in the canal, the microphone on any hearing aid only picks up at a distance from about 6 to 8 feet. Okay? The microphone technology on a hearing aid only picks up a distance of about 6 to 8 feet. So is it reasonable that we fit, let's say a husband and wife combination, we fit the husband with hearing aids and he's in the other room watching television and she's in the kitchen cooking dinner, and she asks him, do you want something to drink or just water? Is it realistic that he will hear her? Well, the answer would be no, but that is a huge component of counseling, because oftentimes family members and friends believe that, well, if the individual is wearing hearing aids, they're hearing everything now. Okay, so let's go back to this first point, the induction loop concept. If an individual with hearing aids is going to somewhere to hear a play, if they're not right in the front row, let's say they're in the middle of the theater, they still, or they're hearing a talk, let's do that, I don't know, they're going to a theater to hear a motivational speaker, let's say. If they're in the middle, they might be picking up a little bit more with their hearing aids on than without, certainly, but they're not, if they're further away, they still are not in the optimal listening environment. They also will pick up other people moving and shifting and ruffling. But if they can set their hearing aids, and again, sometimes this is a manual button that they tap on their hearing aids, or it can set automatically, then the speaker's voice, no matter where they are in the room within the loop, they get that input directly into their ears, amplified by the amount that they need based on the degree of hearing loss, right? Amazing. So imagine if every time you were in an auditorium in a classroom setting and the professor's voice was directly in your ears versus across the room, you would pick up a significant more amount of information and understanding, because it would keep you more focused, because it would eliminate all the background noise. It's enhancing the signal to noise ratio. Okay, so that's an example of an induction loop. The next point, infrared system. So we said this is going to use beams of light to go from the sound source to a personal receiver. This infrared system is typically not used with hearing aids. And let me give you an example. And I'm probably getting ahead of myself. We'll probably see these in upcoming images. This would be like a very popular product is called TV ears, where I'll give you the example of my in-laws, for example. My mother-in-law will say, my father-in-law turns the TV up way too loud to hear. Okay, a way to get around that for the hearing impaired person, and especially if it's an individual who doesn't wear hearing aids, they can put a specific box on top of the TV that's plugged into the TV, and then the light beam, and then the hearing impaired person themselves puts on like a little headphone that goes in their ears and kind of under their chin. So the infrared system is picking up the sound source, so it's picking up the signal from the television and sending it through a light beam across the room into the headset that the hearing impaired individual has on. So then the other people in the house or in the room who may have normal hearing would not need to have the TV up so loud. Okay. Another time this system can be used is if, for example, one person likes to watch TV in bed. So then the sound can be off, but the sound can go directly from the TV to the individual who wants to watch directly into their ears. An FM system is similar to the infrared, so we don't need a wired loop, but instead of through a light beam, it is conveyed through radio waves, or frequency modulation is the term for FM, to a personal receiver. So in a scenario that's most popular with an FM system would be, for example, someone in school, somebody in elementary school, middle school, high school, or college. So for example, this individual would be wearing or utilizing 2 hearing aids, and as far as I know, only behind the ear hearing aids support FM. Maybe. Most likely only behind the ear hearing aids. So either the hearing aids would have an internal setting, or they would have what's referred to as a little boot. And again, I think there's some images coming up that you'll see, where the audiologist clips the boot on and it stays on. So when a child is in the classroom, they can either manually flip a little lever to FM, or it happens automatically. The teacher wears the piece or the loop around their neck. Then through frequency modulation or radio waves, the teacher's voice goes directly from the teacher's mouth directly into the hearing impaired child's ears. Okay? And there can be different settings. The FM system, the child or the teacher can set it so that it only picks up the instructor, or it can also be set to pick up environmental sounds too, right? Because sometimes in certain situations we know that learning comes from what else is going on in the room. Okay, so those are some different types of technology utilized for ALDs, or assistive listening devices. And these are some examples. This is the induction loop system. So as you see, and I'm looking at the picture on the left, there is the induction loop, or the room is, we would say, wired or looped. Here's your speaker through the microphone, and then it's amplified. The amplifier is sending it through the loop, which connects the hearing impaired person. When they put their hearing aid in that mode, picks up that signal. And then here's just another image. So that would be a looped room, and the hearing impaired person can just change their settings to pick up that signal and hear only the speaker. Okay. The disadvantage is if someone in the audience asks a question, and that we're going to talk about when we talk about communication. We're going to talk about what makes good lip readers, good speech readers, good communicators. And one point that's very important for teachers or professors is to repeat the question that is asked in the audience. And this is a perfect scenario. If you were this individual here, so I'm pointing to the far right individual in the front row, and you were utilizing hearing aids and you were listening to the speaker through the induction loop, you'd be getting the speaker's voice directly through your ears, amplified by the amount required for your hearing loss, which would be great. But let's say this person asks a question. Now, this person is at a disadvantage because they can't hear that. So, what the teacher should be aware of and do is, once that question's asked, repeat the question for that individual or any other individuals that didn't hear it who may have hearing loss to the audience. And we'll talk about that with enhancing communication environments. This hearing impaired person, to be an assertive listener prior to the talk, should say to the speaker, excuse me, I wanted to let you know I have a hearing loss and I utilize hearing aids, and it's very helpful if a question's asked if you could repeat the question, because I'm listening to your voice through my hearing aids but can't pick up if others speak. Okay, so that would be, and we're going to talk about as the listener what is assertive behavior, aggressive behavior, or passive behavior. And this would be an example of assertive behavior. So these are things that we would talk about and express to our patients, which is oral rehabilitation, whether we're working with them in a one-on-one scenario or in group rehabilitation. So one option you may choose to do for one of your oral rehabilitation sessions when you put your final project together would be, I want to talk about the different assistive listening device systems and show examples of each of those systems so that the participants in my session are aware of these different systems and see if they are helpful. Okay, and here's where I probably got ahead of myself. So so I did get a little bit ahead of myself with talking about the differences between the two. So when we talk about an FM system, so let's define an FM system increases the volume of a particular sound source, such as a public speaker, teacher, minister, television, etc., and delivers it directly into an individual, directly to an individual, not into is a funny word, directly to an individual without increasing the amount of background noise. So it's enhancing the signal to noise ratio and is particularly useful in the classroom settings. So FM system was what I had just described, and now this is typically going to be utilized with somebody who's wearing hearing aids, where the speaker is asked to wear the loop that sends the radio transmission or the frequency modulated waves from the speaker wirelessly to the individual. Okay, and here's examples of FM systems. So okay, this is a little bit different, the one on the left. I'll explain that in a minute. Here's one in the classroom. So the teacher has the microphone on, she's talking into it, and it's sending it out through radio waves directly to whichever child in this classroom is utilizing amplification. This is another form or another type of FM system. What you're seeing here is actually utilizing a form of Bluetooth technology. This is the person who's wearing hearing aids, and this piece of technology I had shown you in previous images. It's through one specific hearing aid manufacturer, but all the hearing aid manufacturers have this, where it's a loop around the person's neck, and this portion with this particular manufacturer is called a streamer. So this person has a microphone clipped. It's picking up the sound and sending it through FM, frequency modulated waves, directly to the streamer and into the patient's ear. It says about 15 meters, or it's typically works up to about 30 feet. So this system, because it's just a smaller clip, is actually much less expensive for an adult to use versus what's typically provided and utilized in the school district. Okay? Although this system that you're looking here is much more powerful and grows a greater distance. So this is something, though, that is wonderful to recommend. So what you're looking at is the image in the left corner, to recommend to our adult patients who've been fit with hearing aids but are still having difficulty one-on-one. This would be great to use in like a book club meeting where there's one speaker talking, or I've fit this system before with individuals who they say, well, when I go out for dinner with my significant other, I still have difficulty. How this can be utilized then is this person's speech goes directly to the microphone and is sent wirelessly into this individual's ears through the hearing aids. Now this individual can tap a button and mute the background noise, so mute the microphones that are picking up everything, and then the speaker's voice goes directly into the listener's ear. Now, we might pick up some background noise as the waveform goes from the mouth into the microphone, but see, through this system we have significantly reduced, or let's say enhanced, the signal to noise ratio. We've really improved the signal to noise ratio. Okay, so that's kind of the concept of FM systems. So this would be something, the type that would be utilized in school. Here you see in elementary school, but we have graduate students or college students who utilize this in the classroom. This is something more for maybe an adult hearing aid user that's still having difficulty one-on-one in more challenging environments with a lot of background noise. This is an example of the infrared system. So these are, for example, what I was talking about, very, very popular TV ears. So the bottom component, the black piece, would sit on the top of the TV, and it's plugged into the TV. Then the user would pick this up and put it in their ears and can sit across the room and hear the sound source wirelessly. And then here there's a volume control on it to turn it to a comfortable level. Now, they would not be using this with their hearing aids. They would be removing. Or if we had a patient that said, yes, I acknowledge that I have hearing loss, but my main difficulty is hearing the TV and I can't afford hearing aids, or I don't feel like I need them now, but I want help with the TV, this would be an option. And let's see. Oh, this is from a different manufacturer. This looks like something from Widex that, again, is Bluetooth. So if the individual had hearing aids on, this cord is plugged into the piece you see here, and it can stream all different types of devices. So it can stream cell phones, a laptop, a landline, an iPad, an iPod. It's, again, using infrared technology, it's infrared technology streaming from these pieces of equipment through here, and then using Bluetooth technology through the hearing aids. So it's that sort of, those are other options when our hearing impaired individuals are still having difficulty in certain environments, even when they're using hearing aids. So we've brought up the point already that hearing aids alone sometimes aren't the final answer for the patients. We need to also make other options available. Years ago, when I worked in a clinic in Phoenix, Arizona, we actually had an ALD, or system listening device, room. So all these things were set up and working. So patients and their family members could come in and try them, and then decide if they could order them online or purchase them directly through us. But it was nice because they could try them, we could set them up so they actually understood how to utilize these different devices. Because sometimes the technology can be a little overwhelming to some individuals, and then other individuals absolutely love the technology. What you're looking at here is a personal sound amplifier. This is a little bit different, and this is something that that you probably, many of you as speech language pathologists, would utilize in the scenarios that we talked about, individuals who you're treating or you're evaluating at bedside at a hospital or in a rehab center or outpatient, that either their hearing's changed significantly from an injury or trauma, or their hearing aids have been lost, or they're in hospital or rehab and their hearing aids are home or not working. These are pocket talkers. They're the most popular type of personal sound amplifiers. These are typically kept in stock in medical settings to utilize with patients. What this is what you're looking at here in the upper left is the microphone. So the person wears either headphones or even earbuds, and they're also plugged into this piece of equipment. And the person speaking would hold this portion and talk into the microphone, and then the wire would transmit the sound to the headphones. Okay, and these are just different clips. We sometimes we utilize this Okay, this is important. In our group oral rehabilitation sessions. So remember I had said that I would do these sessions with the graduate students in Arizona. We would go to senior centers and advertise the session, and then we would get maybe 15 to 20 individuals, and their spouses or family members were welcome. Every once in a while we would have an individual who didn't have hearing aids and really couldn't hear. I mean, really had so much hearing loss that they couldn't hear in these environments. So we always brought a couple of these from the clinic. And what I could do is set them up on the table. This cord would actually, we could take this microphone out, okay, pop this out, put it on one end of the cord and plug the cord in. That way the microphone could sit by the speaker, and then the individual would have the headphones on and can turn the volume up on these. Now, these are, oftentimes people would try these and they say, wow, this is amazing. I'm actually hearing. Why wouldn't I just get this instead of hearing aids? Because this whole setup is probably about $125, right? Compared to thousands for hearing aids. Well, here's why. These, of course, are not modified for the specific hearing loss, right? Because we know now with digital technology, we're taking that individual's audiogram, their thresholds, their speech reception, their word recognition scores, we're inputting them in the computer, remember, called NOAA software. Remember, NOAA stands for nothing. It's not, I mean, it's not an acronym for anything. We're putting the scores in, and then we're wirelessly transferring the scores in the hearing aid. So their individual hearing aids are set so it only boosts sounds in areas where they need. These types of personal sound amplifiers boost across the frequency range. So it's louder in some areas than probably the patient needs, and not as loud in others depending on the hearing loss. But oftentimes you get that wow effect where people put these on, like, wow, I'm hearing. The other thing, these are bulky, right? You wouldn't really want to carry this around with you all day and wear headphones. So, and the components break and get moisture. These are often can be utilized in hospice. So if an individual is under hospice care and their hearing aids are broken or they're not working or they're lost, it certainly wouldn't be appropriate to refer and charge those individuals and the family for new hearing aids. So these also can be very helpful equipment at that time of end of life, so that that individual can communicate with caregivers and family members. So these are personal sound amplifiers, and the one that's most popular is going to be a pocket talker. And I could probably guarantee you, as speech language pathologist, you will be familiar with these, particularly working with an adult and specifically a geriatric population. There's also assistive listening devices for telephones. So some of these you see right here would be or are utilized by deaf individuals, right? Individuals who essentially have no residual hearing, who aren't utilizing hearing aids, and who choose not to have a cochlear implant, so that when the phone rings, everything is seen in text and then you respond in text. Some of these, that's what you see, or some of these have both options. So the person can get the message in text and read, but then talk into the phone. And that's what you're seeing here. Also, you have an option of getting larger buttons for somebody who's visually impaired. This is also an old style of a TTY, which is a telephone that does text. So the text runs across here and the receiver sits in here when the person calls. This is also a very old style. What this would do would be to clip over the top of a landline phone, and it has a volume control on it. So it just is basically turning the sound up louder as it's coming out of the receiver, the earpiece on a landline telephone. So there's telephone options. We've also talked about the Bluetooth technology, so that there are certain pieces that an individual can wear around their neck, and we can pair their cell phone device to it, their cell phone, so that when their cell phone rings, their hearing aids become a wireless headset and the piece around the neck becomes a mic. The advantage of this is they're streaming binaurally. So when that phone rings, it rings in both of their hearing aids. They tap a button on the piece that they're wearing, and the hearing aids become a wireless headset, and the signal is going into both ears versus just one, making it louder, much easier to hear. The other really cool thing about that technology, let's say I had those hearing aids on and I was in Costco and it was really loud, and my husband calls and says, hey, don't forget to pick up vitamins when you're there. But I still can't hear him because of all the background noise my hearing aids is picking up. I can mute the microphone on my hearing aid and only hear through the cell phone. Okay? Again, enhancing the quality by reducing the background noise. These are wonderful devices to recommend to our patients. So for example, somebody who's still very active, perhaps active in their career, they are on the phone often, on cell phones, on calls on the cell phone, that it's very important they get their information. What wonderful devices to be able to offer that are in addition to their hearing aids. They're not going to replace their hearing aids and actually are rather reasonable. We're talking about only a couple $100s versus thousands for FM systems, or the larger one like you saw utilized in a school environment. Alerting devices are another type of FM systems. Some of the things you're seeing here are smoke alarms. So when the smoke alarm goes off, a deaf individual may not hear the alarm, but they have lights that flash. This can also be connected to baby monitors, right? A hearing impaired or a deaf mother. When the baby is crying or talking through a baby monitor, there can be an alerting device. These would be wristbands that light up or vibrate to alert the mother, and they can be set differently. Maybe one vibrating pattern, okay, that's the baby monitor, another vibration or light flashing pattern, the doorbell's ringing, another one for the phone. So these are all alerting devices that can be flashing lights, a wristband that vibrates, those kinds of things. These are really neat that you're seeing here on the lower right hand are alarm clocks. There's one alarm clock that's funny called the Sonic Boom that I think is 120 decibels when it goes off. I mean, unbelievably loud. What these are vibrating alarm clocks. So you'd set the alarm clock and you would put it inside your pillowcase, or underneath on the bottom of your pillowcase. So when the alarm clock goes off, because most or hearing impaired individuals don't wear their hearing aids in bed, okay, most of the time, where we recommend that they don't. This way, if they're not hearing their alarm go off, it vibrates in their pillowcase to wake them. So these are different alerting devices, and they can be set for, again, the phone is to alert the individual, the phone is ringing, the doorbell is ringing, the baby monitor is making sound, the alarm clock is going off, the fire alarm's going off, okay, alerting devices. Bluetooth compatibility. So we've talked about this quite a bit. And here is I don't want to favor any one manufacturer, but I liked this image. This is from a hearing aid manufacturer called Oticon. So these would be, and actually you would wear any style hearing aid, right? So remember what you're looking at here are behind the ear hearing aids, but they are receiver in the canal or the receiver in the ear. You might not know that by glancing at it, but I'm familiar with these. So the receiver, or the speaker, is here, the piece in the ear, and we already know that the greater the distance in space between the microphone in here to the receiver, the more gain or boost or power. So the individual is wearing these, and then they're wearing this piece. It's a loop around their neck. So when the phone rings, they hear the phone, this begins flashing, and they can tap this to answer the phone, a volume control to turn it up and down. They can connect it to any music devices. So this button would be for everything else, basically, for music, iPad, computer, GPS in your car, any of those things. So this is Bluetooth compatibility, or also could be thought of beyond the hearing aids, in addition to hearing aid technology. This is a list of what you'll find, I think, about helpful resources in addition to your text. So this was kind of an overview of what ALDs are and some of the most popular types. One thing that I want you to be thinking about is, as you gather information for your final project, perhaps one of your 4 sessions may be geared towards the review of assistive listening devices and having handouts or a discussion, maybe even a PowerPoint slide to go through, maybe to borrow these devices from a clinic so you could lay them out and have your patients look at them and try them. So assistive listening devices could be helpful in one of your sessions. I think that knowledge of assistive listening devices and reviewing those with our patients is something that audiologists probably fall short in. Typically, if they don't carry them in their office, oftentimes they don't think to say, you know, I know you're struggling with your hearing aids still, or there's still some difficult environments. Why don't you think about X, Y, and Z? So this could be a very helpful discussion that you may use one of your oral rehabilitation sessions for. Okay, the second part of this PowerPoint slide is called implantable hearing aids. So when we talk about implantable hearing aids, we're talking about, obviously, hearing aids that are surgically implanted by an ear, nose, and throat physician. Okay, so let's talk about implantable hearing aids. The first type of hearing aid that I want to talk about is a bone conduction hearing aid. And really, we're going to look at 2. We're going to look at the concept and then look at an implantable. First, remember the concept of bone conduction, which you should have learned about a little bit. We talked about in basic, but also hopefully talked about and practiced in advanced audiology. Bone conduction, this is what you're looking at sort of here without the hearing aid piece, is a bone conductor, a bone oscillator, right? You have the headphone and then you have the piece that vibrates here. So let's say we put that bone oscillator or vibrator right here behind the ear on the mastoid process. When sound vibrates, it bypasses, right, the outer ear, the ear canal, the middle ear. It's really bypassing. It's going through bone directly to the cochlea, where the cochlea, the inner and outer hair cells, pick up the sound. Okay, so that's how we can verify if it's a conductive loss, right? Because if there's fluid in the middle ear, let's look right here where the eardrum is, fluid in the middle ear, and we send sound through headphones in, that sound has to be louder. We have to turn it up louder than normal to push through the fluid to eventually be picked up by the cochlea. If we send the sound through and it gets through the bone and the cochlea hears it at normal levels, then we have, remember when we look at an audiogram, an air-bone gap. The bone conduction scores are better than the air conduction scores, and because we know that the sound went straight to the cochlea versus getting caught up or needed to be turned up louder to get through the middle ear. Okay, so we can utilize that concept for a hearing aid. This type is kind of an old style bone conduction hearing aid where this portion would sit behind the ear, or typically not even, this is really an old one, we would have a volume control over here and a wire to the vibrator. When sound hit it, just like your bone oscillator, so the individual would be wearing it and it would send the sound directly to the cochlea. So you may be thinking, well, when would we utilize this? Most of the time it would be, let's see if I have it. Okay, I don't think I do. Most of the time we would utilize this sort of setup when a baby has atresia or microtia, small external ears or absent. So you can see here with this baby, there's no opening for the external ear. So if we put headphones on this baby, we probably have to crank the sound up to 60 decibels till it's loud enough that it's actually vibrating and the cochlea hears it. But when we put a bone oscillator, and that's all this is a vibrator back here, vibrate, the sound goes directly to the cochlea. Assuming it's a normal cochlea, they would hear normally. So we have to bypass the portion that's closed. Okay, so we could do these with a headband, but once the baby's that the head is large enough to have surgery, then we're going to talk about a bone anchored hearing aid or surgically implanted. But for now, it's important for you to understand the concept behind a bone conduction hearing aid. It's vibrating the mastoid and sending the sound directly to what we hope to be a normal hearing cochlea. So, sound via bone conduction. A bone conduction hearing aid uses the body's natural ability to transfer sound through the bone, right? When it's loud enough, it stimulates the bone and goes right to the cochlea. A bone conduction hearing aid works by conducting or carrying through vibration the sound through the temporal bone, and the cochlea hears it and then passes that sound directly to the auditory nerve. The sound bypasses. So it's bypassing the middle ear and directly stimulates the inner ear or the cochlea. Okay, and again, that's the same image. So again, let's just review the concept of a conductive loss. All right, so as an audiologist, let's go step by step. I take the case history, I look in the ears, blah, blah, blah. I obtain thresholds first. The first thing I'm going to do is get air conduction thresholds. So let's assume this was a 10-year-old, okay? I put the headphones on. The 10-year-old says it doesn't feel like one ear's better than the other. Then I typically start with the right ear. And I obtain the air conduction thresholds, right? At each frequency, 1,000, 2,000, 4,000, 8,000, 125 hertz, 250 hertz, I use the ascending-descending method to obtain threshold, or the point that it's barely audible 50% of the time. Okay, and I mark the scores. So here's doing that through headphones, the right ear and the left ear. That's step 1. Then I get the left ear, step 2. Now, if I only had these right circles and these blue X's, I couldn't say, well, let me back up. If we're only looking at the right circles and the left X's, I think we can all agree, based on the scores, we have a hearing loss, right? If we say that the 20 line and above is normal, 20 dBHL and above is normal, then I think we can all agree we have a symmetrical, the ears are essentially the same, we have a hearing loss. Now this is really important, so for those of you who are confused, really focus on this. At this point, if we were only looking at the red circles and the blue X's, we could say with confidence, this person has a binaural, both ears, symmetrical, the same, mild hearing loss. But without anything else, we can't say, is it conductive or sensory neural? Now, I put the bone conductor behind the right ear, and my scores, when the person hears the sound, they go here. That's telling me that when I send the sound directly to the cochlea, we have a normal cochlea. And for those of you who are wondering, well, why would you put it behind the right and the left? Yeah, right. We're not going to go into masking, but let's just for argument's sake say that the cochlea responded normally. That's telling me that there's something impeding the sound when we go through the headphones, but when we get to the cochlea, it's normal through bone conduction. The cochlea is hearing normally. One typical guess may be fluid, right? An ear infection. And if that were the case, we would refer back to the pediatrician or to the ear, nose, and throat physician or the primary care. They would see this. They would possibly put the 10-year-old on antibiotics. 2 weeks later, we test him, and then the circles would be up here white with the bone conduction. Okay? Conductive loss. If, for argument's sake, we put the bone conductor on and the scores fell right along in line with the circles, and over here right along, we would know when we stimulate the cochlea, there's also a hearing loss, making it a sensory neural hearing loss. Okay? Yes, good, we've got it. How we would describe this is there is an air-bone gap. Our air scores versus our bone scores. There's a gap between the two, a conductive loss. Okay? All right, just for argument's sake, what if these bone scores were up here at 250 hertz, and again the frequency's down here, I know we're used to seeing it up here. If the bone conduction scores were here, but then they went down to here. We have a mixed hearing loss. There's a conductive component, but also a sensory neural component. If then the bone conductive scores for the higher frequencies, that could very well mean you have a person who typically has a mild hearing loss, mild high frequency hearing loss, who just happens to have an ear infection. Okay? Hopefully, again with all these examples, hopefully it's kind of solidifying the concepts. All right. A bone-anchored hearing aid. So this is using the bone conduction technology, but instead of an individual having to walk around all the time with a headband on, it's implanted and it's much more discreet. So what you have here is there is a piece implanted in bone right here. Let's look at this figure. This piece is surgically implanted in the mastoid, and it's called an abutment. And then you have this piece, which is the sound processor that the patient pops in and out of the abutment. It just pops in. And this can be tuned as needed to the degree or configuration of the hearing loss. So sound comes out, stimulates through the microphone, is amplified as needed, goes through the bone, stimulates the cochlea. So this is called a BAHA, or bone conduction hearing aid. Okay? Here's a step that can be a little confusing. Okay, this can be confusing. BAHAs, or bone conduction hearing aids, can be fit when a person has bilateral microtia or atresia, so maybe in both ears the outer ear is so misformed that there's no outer ear, no opening in the ear canal, like for example with different types of syndromes or genetic syndromes. That could be a reason. Or it can be, so a BAHA would be utilized, and it could be utilized in one ear that stimulates both cochlea or the better cochlea, or so it can be utilized for conductive hearing losses like that, or, and bear with me now, single-sided deafness. Okay, and this is where it gets a little confusing, and that shows this image. This ear is getting sound through air conduction. It's saying air conduction the normal way, so through the ear canal, through the middle ears, directly to the cochlea. The BAHA would be put on the deaf ear for individuals who have single-sided or hearing loss in one ear, deafness in one ear. This is put on. It also stimulates the cochlea, giving the perception that sound is coming from the left, and it honestly works wonderfully. Individuals with single-sided deafness who utilize a BAHA typically feel like, again, they have localization capabilities, that they're getting all the sound from the left that they didn't get before. This is typically what it looks like. There is the piece that is implanted in bone under the skin, and then the piece that connects to it, and then the sound processor. This is typically outpatient surgery, needs to heal for a couple weeks, some risk of infection at the incision site. It's checked by a physician, then the processor is fit, the audiologist fits a processor, and the patient is taught how to use it, clean it, take care of it. And the processor portion is popped off at night or anytime that person doesn't want to hear the sound. And then this is what it looks like. If it's in a place, typically hair covers it, and it's very discreet. how the BAHA works. It can be utilized, like we talked about, of conductive hearing loss, like microtia or atresia. If for some reason that patient isn't able to undergo surgery to open up those ears, or maybe their middle ear is so wasn't formed correctly or destroyed and they couldn't have surgery, then it can work for a conductive loss. We talked about single-sided deafness, so it can work with there's a sensory neural loss to give the perception of sound from that side. A difference between bone conduction hearing aid, which is a headband, and a BAHA. Before the advent of BAHA, or an implantable bone-anchored hearing aid, we fit all long-standing conductive losses with that bone conduction hearing aid or headband. And that's typically not the case anymore, because people, and even children, when their head is developed enough, parents opt for a BAHA. When we look back, let's look back at this image. This style versus the headband, this is typically fit on a child for a trial period to see how the child responds before they actually undergo implantation for a BAHA hearing aid. All right. Oh, and this is an audiogram revealing single-sided deafness. So if we look at this audiogram, we have hearing loss in dBHL on this side. On the top we have frequency in hertz, and we have the circles, which are our right ear. And I think we can all say that the right ear is normal. The blue squares are the left ear. Okay, now bear with me. They're squares instead of X's because they're masked scores. Okay, now remember this from basic and advanced aud. Once we get, when we're testing with headphones, more than a 40 dB difference. So let's say I'm testing the patient's left ear. If I ask the patient, which is your better ear? They say, oh, my right ear's fine. I'm going to test the right ear first. Then let's say, okay, I'm switching to your left ear. If I'm testing at 1,000, and I start at 30 and they don't hear, and I turn it up to 40 and I turn it up to 50, once I get greater than 40 dB above the non-test ear, the sound is loud enough, the sound that I'm presenting, that beep at 1,000 hertz, once it's 40 dB louder than this threshold, it can actually cross over, again through bone conduction, and be picked up at the right ear. So masking needs to be applied. I need to put masking in the right ear, right? Narrowband noise, shh. Masking in the center frequency is going to be 1,000 hertz to keep this right ear busy while I test the left ear. So these are mass thresholds, knowing that it didn't cross over. So if we don't look at the bone conduction scores, we see that the mass left ear thresholds reveal a moderately severe to profound hearing loss. These are mass bone conduction, right? Because if I put the bone conductor on, it's going to respond to the better cochlea. So again, I need to mask the right ear to get the left mass bone thresholds. Now, this is interesting. These arrows mean at the maximum limits of the equipment, as do those, that it couldn't be turned up any louder. But what I'm concerned is here. This is actually a bad image because this is looking more like a mix loss. For argument's sake, let's assume that these were at the limits and these were at the limits, and let's assume this is a sensory neural hearing loss. Okay, because this is the bone conduction scores are misleading. Because it is a mixed loss. But let's assume that the bone conduction scores all fall down here. Then it is a single-sided, essentially deaf individual who could be a candidate for a BAHA in that ear to give the perception of sound. It's actually sending that sound over to the right, but the perception is it's coming from the left, and it actually works very well, and people are typically very pleased with the surgery. There is, before we go on, there is another type of hearing aid that is non-surgical, when we have single-sided deafness. And it's called a cross hearing aid, CROS, and that stands for contralateral routing of signal, or cross. Basically, and let's look at this test, you would have a hearing aid and an ear mold in the right ear. Okay, and you would only have a hearing aid with no ear mold, a behind the ear hearing aid, in the left ear. Here's the concept. The microphone on the left picks up the sound, wirelessly sends it to the right, and then delivers it to the right ear. Okay, that's the concept. I don't know if you want to think this out. If I was in front of you, I would ask you, why is this not often satisfactory to patients? Well, because typically they have one normal ear and now all of a sudden they're wearing 2 hearing aids. It's not necessarily cosmetically pleasing. It feels bulky. The other problem is it's sending the sound that they're missing from the left ear to the right ear. So they're actually, instead of perceiving it from both ears like a Baja, because of the acoustics, they actually, all the sound comes to the right ear. So they'll always look to the right side. Now, sometimes this scenario works, like if somebody says, well, I'm often in a conference room and I can't miss anything on my left side, but rarely, in my experience, cross aids are difficult and rarely accepted by patients. But it's an option, and it's a non-surgical option. All right, let's talk about cochlear implants. And this is really just giving you sort of the basics. A cochlear implant is a small, complex electronic device that can help provide a sense of sound to a person who is profoundly deaf or has a severe to profound sensory neural hearing loss. The implant consists of an external portion that sits behind the ear and a second portion that is surgically implanted under the skin, and actually a third portion, an electronic array that is surgically placed inside the cochlea, or the inner ear. So there's really 3 portions to the cochlear implant. Cochlear implants have the following parts. I'm going to kind of read through this. First of all, the microphone on the outside, which is going to pick up the sound from the environment. It's going to then go into a speech processor, which selects and arranges the sound that's picked up from the microphone. And it's this portion, the speech processor, that the audiologist works with the patient as far as the sound quality they're receiving. Then you have a transmitter and receiver, stimulator. It receives the signal from the speech processor and converts it into electronical impulses. Those impulses are then next transferred to an electrode array, like a strip of electrodes that are laid surgically along the inside of the cochlea. This is a group of electrodes that collects the impulses from the stimulator and sends them to different regions along the cochlea and then along to the auditory nerve. Okay, so you can see already it's quite invasive. An implant does not restore normal hearing. Instead, it can give a deaf or profoundly deaf deaf individual, a useful representation of sound in the environment and help give them cues to understand speech. Some individuals are very successful implant users, others are not. Typically, when we implant young children as babies, and now the FDA has approved cochlear implants down to 1 year of age and has approved 2 implants, so 1 binaurally in each ear. As they're learning speech and language, they can utilize an implant better than an adult, particularly an adult who has been deaf throughout their life. Oftentimes, for example, I have a friend that had normal hearing till she was 5 and had meningitis and then became completely deaf. As an adult, she decided to have a cochlear implant. She didn't like it at first and went through many sessions of programming and is actually able to work with it very well now because she had some memory of what speech sounded like. So she was over time to be able to process the sound she was hearing again. So again, this is what it's going to look like. Here is the transmitter that connects to a magnet under the skin. The sound is picked up, it's sent to speech process, or I'm sorry, backwards. The sound is sent through a microphone into the speech processor, then to a magnet on the outside, and then the magnet is the receiver or stimulator. Then it is sent into an electrode array inside the cochlea that sends it to through different regions of the cochlea and to the auditory nerve. Again, here's the different components. From the sound processor, which also houses a battery, sends it to the transmitter, which is a magnet. So this portion and this portion can be removed, and then there's just the kind of the abutment or the magnet that you would see under the skin, barely. And then the electrode array inside the cochlea. And this is really what it looks like. So here's the sound processor, here's the magnet. Again, at night this part can just be popped off. Here it is in the baby, and where it's put in the head depends on the surgeon and the anatomy. Typically it's put as close behind the ear as possible. Here's another image. Criteria for implants. As of December 2012, approximately 324,200 people worldwide have received cochlear implants. In the US, roughly 58,000 adults and 38,000 children. In 2000, the FDA lowered the age of eligibility from 18 months to 12 months of age. Some surgeons have implanted as young as 8 months. I put a reference there because I found that, and that was actually surprising to me. And adults, if they read the criteria, can be implanted at any age. Okay, the cost. So let's talk about the cost for this. The cost for cochlear implant surgery, which includes the device, can range from $50,000 to $100,000 depending on the surgeon and the hospital. Many commercial and public insurers actually cover the cost as well as the pre-op and post-op services, and we'll kind of review some of those. There are warranties on these components, but some additional costs for summer replacements, and then also the batteries is an annual expense. But there are many insurance companies that will cover this device, and particularly for children if they meet the requirements. But I want to give a very brief discussion. Well, we talked about the procedure. What I want to note is the team approach. This is very, very important. There is a lot of counseling prior to implantation. The parents, there has to be family support because there's going to be a lot of appointments as far as follow-up from the surgery itself, the surgery, programming the hearing aid. And programming is this word called mapping, or setting the sound quality. Is it loud enough? Is it too tinny? Is it too sharp? What is the child actually receiving? Activation is when they first turn it on, because a surgeon will implant, but there is a healing process before the external part is put on and turned on. If you have a moment, and I didn't put any of these links on, go to YouTube and look at cochlear implant activation, and you will see some unbelievable, moving videos of both children and adults when they're deaf children, but their implant is activated for the first time. But team approach, we're talking about ear, nose, and throat, audiologists, speech language pathologists, counselors, caseworkers. Definitely takes a team because the support is needed for them to be a candidate, because there is a lot of support. It's an invasive procedure surgically and a lot of ongoing follow-up. One thing I want to talk about, when we talk about deaf implants, we have to acknowledge the deaf culture. And when I'm talking about deaf culture, when we talk about deaf as in lowercase d, we're talking about a profoundly hearing impaired person. When we talk about deaf, as far as deaf culture, we're talking about a capital D, as in a group of people, a culture among a group of people who are severe to profound, who have severe to profound hearing loss. There are some very, very strong feelings among the deaf culture about cochlear implants, and I think it is definitely worth your while to look at these two resources. The feelings, I think now there are more mixed feelings than ever, but kind of to summarize, the feelings in the past and still currently among many deaf individuals, the capital D, referring to deaf culture, are that a cochlear implant is taking away part of who the person is. But how they feel that is, if an individual is born deaf or becomes deafened, that is part of who they are, right? Like the texture of your hair, the color of your skin, the color of your eyes. Are you artistic? Are you... It is a characteristic of who you are. And they feel that cochlear implants are taking away that characteristic and that deafness of who they are. So it's been very strong feelings. The deaf culture often has very strong feelings about implanting children. Before a child, if we can implant a child at 12 months, well, that child hasn't really had an opportunity to say, no, I want to be a deaf person. I don't want to be implanted. So there's been a lot of controversy on this topic, and I think these are definitely things that you need to be aware of, especially both in speech language pathology and audiology when we counsel patients. When we counsel deaf patients, when we talk to parents, both deaf parents of hearing impaired children, which is rare, just genetically, or hearing parents of deaf children, it's very important that I feel that those hearing parents of deaf children review a lot of the sources and talk to deaf adults about the feelings of the deaf culture and how they describe their deaf culture, how they identify themselves as being deaf individuals, and their feelings about cochlear implants. I feel that as an audiologist, this is important information to give hearing parents of deaf children prior to making the decision to implant. So, good resources to look at. Okay, so that ends this very long slideshow about assistive listening devices and cochlear implants. I think it's obvious, and we've talked about how we can utilize assistive listening devices in rehabilitation with our patients. It gives us another option beyond hearing aids. Cochlear implants also, like hearing aids, this can be an option for rehabilitation to offer to our patients. Alright, so we'll pick this up again, and this will be the end of this slideshow. Again, if you have any questions at all, or as we review audiograms and degrees of hearing loss, conductive versus sensory neural, bone conduction, please feel free to email me. And if we need to meet via Google Hangout or speak on the phone, absolutely welcome to do that. All right.